Good morning, and a very warm welcome to this inaugural symposium for SHARE, the Sexual Health and HIV All East Research Collaborative, which is a novel, multidisciplinary academic collaboration between Queen Mary University London and the Barts Health NHS Trust. My name is Sheila Gupta, and I joined Queen Mary as Vice Principal for People, Culture and Inclusion in January 2020, and I'm delighted to have been invited to chair this symposium event. I'd like to say a few words about why this innovative, exciting collaboration is so important to us at Queen Mary and the Barts Health NHS Trust, because it is absolutely central to turning our vision of opportunity and inclusion into reality. Where we demonstrate how collaborative research through projects such as this can deliver transformative health benefits for our communities in East London and beyond. Next slide, please. Thank you. My reason for coming to Queen Mary is because it is a truly unique and distinctive university. Our vision, mission and values articulate our commitment to promoting social mobility by placing inclusion and the values-based culture that we espouse at the heart of achieving our academic ambitions. With a core vision of health equity, SHARE is an exemplification of our joint mission and values. There could not be a stronger alignment across the academic aspirations of wanting to address health inequalities and affect our frequently marginalised communities in East London and beyond. Next slide, please. Our strategy espouses the importance of diversity and inclusion to fostering a highly successful research culture that can truly transform and improve the world that we live in through the research that we perform. Previous slide, please. Apologies. This quote from our principal, Professor Colin Bailey, encapsulates why diversity of thought, interdisciplinarity and innovation are seen as pivotal to us realising our academic ambitions. Next slide, please. So I'd now like to say a few words about the SHARE Collaborative. So the aim of SHARE is to develop a sustainable centre for research excellence. And what it does is it brings together expertise across clinical services, clinical trials, evidence synthesis, health informatics, community and participatory research strengths, which translate basic science into health solutions. And the focus of our research efforts are very much on HIV prevention, diagnosis, retention in care, comorbidities, and novel therapeutic interventions. And we care very much about focusing on the needs of our East London communities. Our approach is very much about identifying and tailoring our interventions so that they address the particular needs of our communities in East London. And we are person-centred. We start with the individual. And what we do is we incorporate and translate benchside findings into population interventions through our extensive collaborative network within the community. And the ultimate goal, to deliver a portfolio of high quality, innovative research that directly impacts and transforms practice and policy. Next slide, please. Broadening representation is at the very heart of what SHARE and Queen Mary stand for. There's a clear gap in representation, both in terms of the participants who engage with our research and indeed the researchers themselves who are shaping and delivering the research work that we undertake. And there is a paucity of representation of women, of those from racially minoritised groups, and indeed other marginalised groups. So we intend to be proactive in terms of diversifying our research community, in keeping with our commitment of seeing inclusion as the essential feature of our whole approach to ensuring a successful research collaboration. We will address removing social barriers as well as delivering high quality research. And we aim to bring this to life through the visions that SHARE and Queen Mary share by actively bridging that inclusion gap. And we will do so by investing in the development of 3 very talented early career researchers, people who've already published and who already have secured blue chip grants. And I'm very pleased to say that 2 of the 3 early career researchers are women from racially minoritized backgrounds. So hopefully we are actually living our vision and bringing to life what we say is important to us. Next slide, please. Our work will be both collaborative and multidisciplinary. For us, it is really important that through the work of the SHARE Collaborative, we will bring together senior clinicians and researchers with complementary skills across Queen Mary and the Barts NHS Trust. And this will cross traditional subject and methodological boundaries, drawing together a unique, wide-ranging academic portfolio, which enables us to address the interdependent, multifaceted challenges that influence outcomes in HIV and sexual health. Thus, by bringing these varied disciplines together, we will actually have the power to deliver a significantly more impact, demonstrating the value of why such an inclusive approach delivers more impactful research outcomes for our communities. And that brings me to my final point, which is the fact that the work we undertake is very much rooted in the community. And that is vitally important to all of us at SHARE and to all of us at Queen Mary and Barts. So in essence, underpinning the collaboration, SHARE will make sure that it establishes partnerships with the communities who are most affected, and that it will engage with key stakeholders to ensure that there is diversity in participation in this project. We will ensure that the work is consistently relevant and that the outputs and the impact are widely disseminated. And finally, the Barts Charity Grant and the investment in this group is absolutely pivotal in enabling the collaborative to create a legacy by delivering community-driven research across the full spectrum of the continuum of HIV care, from diagnosis to cure research. So that really encapsulates everything that this whole initiative is about. And we really look forward to embarking on what we believe will be a very exciting, ambitious, and fruitful journey. I'd like to now just introduce Professor Chloe Orkin, who is the SHARE Collaborative Director, and who will shortly be talking about why we need to focus on health equity, an East London clinical academic perspective. And I'd like to say a few words by way of introduction. Professor Orkin is Clinical Professor of HIV Medicine at Queen Mary University London and Consultant Physician at Barts NHS Trust, Health NHS Trust. She has been the clinical lead for HIV research at Barts Health NHS Trust for the past 15 years and is considered an international expert in HIV therapeutics. She was the immediate past chair of the British HIV Association, is the current president-elect of the Medical Women's Federation, is NIHR North Thames BRAIN Inclusion co-lead for COVID-19, is the Athena Swan Self-Assessment Team Chair for the School of Medicine and Dentistry, and is on the Governing Council for the International AIDS Society. Chloe also researches tackling health inequalities and gender inequalities in academia and society. And during the pandemic, she published on disparities in health outcomes in ethnically diverse communities and on gender inequalities in academia. Please welcome Professor Chloe Orkin, Director of the newly established SHARE Collaborative. Chloe, over to you. Thank you very much indeed.
Thank you so much, Sheila, for that warm and very supportive introduction. It means a lot to us to have the university's support, and thank you to Barts Charity for supporting us. Thinking about HIV in 2020, we've come a very long way. Successful treatment stops HIV transmission, and this is the incredibly powerful undetectable equals untransmittable message. There should be no doubt that a person with sustained undetectable levels of HIV in their blood cannot transmit HIV to their sexual partners. And that was the British HIV Association's statement to support this initiative. Early diagnosis and 1 pill a day can equate to a normal life expectancy for most people with HIV. Antiretroviral therapy leads to the fact that almost all babies are born without HIV, which is an incredible achievement for science. Pre-exposure prophylaxis is around 90% effective. However, Even in 2020, with all of these advances, progression to AIDS and death still occurs in people who are diagnosed late, in people who disengage from care, and in people who find oral treatment hard to take, i.e., when our services are hard to reach and our treatments are hard to take. London has set very ambitious targets of getting to zero. That means zero new transmissions, zero preventable deaths, zero stigma and discrimination, with the aim of wiping out AIDS by 2030. And here we see Professor Jane Anderson from our group as a key protagonist of this initiative. London has exceeded this target. 95% of people are diagnosed, 98% are on treatment, 97% are undetectable, and this is the best cascade of care in the world. However, at Barts Health, our outcomes are not as good as this. If you look at the benchmark in green for London and you look at our outcomes, you can see that these are significantly at variance with the London outcomes. Barts Health has the highest rate of late HIV diagnoses in the UK, as you can see in the red box. Why is this? Let's look at the national picture. Ethnically diverse people are disproportionately affected by HIV in the UK. New diagnoses are going down in men, but not in women. 80% of women living with HIV are from ethnic minority groups. Women and racially minoritized people are more likely to be diagnosed late. 63% of Black Caribbean women, 53% of Black African women, and 47% of white women are diagnosed late. Late diagnosis is an important predictor of mortality. We serve some of the most diverse and deprived people in London. And this is the index of multiple deprivation, evidencing this across our patch. Our cohort is richly endowed with women, with Black African people, and with a lower proportion of men who have sex with men than the green national picture. And this makes our cohort very different from the rest of London, and the needs of our population need to be addressed in targeted and meaningful ways. What about the big picture in the world? There are 40 million people living with HIV. More than 50% are women. Our clinic population is representative of the global picture, meaning that the things that we discover and learn are relevant to the global picture. There are global gender differences in HIV. 3 in 5 new infections amongst 15 to 24-year-olds are in women, with 5,500 young women a week being diagnosed. HIV prevalence among trans women is around 20%, and trans women are 49 times more likely than cis people to be living with HIV. These vulnerabilities are created by unequal cultural, social, and economic status. So where are the interventions needed? Well, quintessentially and very clearly in terms of health inequities, in prevention, in addressing comorbidities, and in long-acting treatment and cure research. This model is applicable to other medical conditions. And here you can see work that we led together with the ITU teams on ethnicity and outcomes in patients hospitalized with COVID infection in East London. We found that the admissions to Barts Health hospitals, 60% of our admissions came from ethnically diverse communities. Asian and Black patients were much younger at admission. Asian and Black patients were at increased risk of age and sex-adjusted risk of death, despite controlling for confounders and frailty. If I had a penny for the number of times I have heard the phrase that COVID has exposed health inequalities, these disparities are not new. I will now read out the words of my colleague, Dr. Ragashree Derawan, in the BMJ Leader Series. In comparison to white British people in the UK, Black women are 5 times more likely to die in pregnancy. Black men are twice as likely to be diagnosed with prostate cancer and proportionately more likely to die of it. Black people are more likely to have severe mental health symptoms, but less likely to receive treatment for them. South Asian and Black people are 3 to 5 times more likely to start kidney dialysis and to be diagnosed with type 2 diabetes. Black people are more likely to have hypertension and more likely to be diagnosed with asthma. Women from minority ethnic communities are more likely to have never had a cervical smear. In HIV, 74% of heterosexual people receiving HIV care in the UK in 2018 were from ethnic minority communities. I repeat, these disparities are not new, and they are related to the inherently structural racism that exists in our society and the inequities that that leads to. We are only as blind as we want to be. Who should conduct research into health or gender disparities? Here is a panel on promoting breastfeeding. See if you note the inconsistency or problem with this image. In fact, there's a source of at all male panels which can share that this is not a new problem. This is not distinct to Mexico. And I'd also point out that this image was in 2018, not in 1922. Who should conduct research into health or gender disparities? There were recently concerns raised after no Black principal investigators were awarded funding for COVID in Black and Asian minority ethnicities call for research. There was a row over the absence of Black PIs, and Black academics have called for changes to the funding processes. In the United States, Black scientists were less likely to receive research funding than their white counterparts because they were more likely to propose studies in community research, including health disparities and patient-focused interventions. There was a lack of evidence on the health of ethnic minority communities due to a lack of demand for evidence from policymakers and limited visibility of this field in leading medical journals, limited competence and confidence among researchers, and low representation of ethnic minority researchers within academia. Participants, interestingly, also thought that charities and social science funding streams were more ready to fund such research than the National Institute of Health Research. So that's really telling. This is no secret or no surprise to the participants in research. This is work that I led as part of an international collaboration with Harvard and the University of St. Andrews. And what we showed is that less than 1/3 of COVID-19 clinical trials globally are led by women. And this is half the proportion observed in non-COVID trials. We aim to develop culturally competent, community participatory, qualitative and quantitative research. We hope that our communities will say the following: I will have the same health outcomes as the rest of the UK. I will feel confident that my research views have been implemented. I will have access to state-of-the-art long-acting treatment and cure research. I will know that the basic science research that occurs represents people like me. I will be able to access trials across the Barts Health footprint. I am seeing changes in the way my care is delivered. It gives me enormous pleasure to present our next speaker, who is the wonderful Angelina Namiba. She has done incredible work for women in HIV and been an incredible advocate and a real driver of change in the way that we work with communities and the way that we understand the needs for research. She has been an incredible role model to Black women and in fact to all women living with HIV. And it's a real privilege to hear her speak out on why we need to focus on health equity. Thank you for being here and presenting an East London community perspective, Angelina.
Thank you very much, Chloe. This is what I'd like to say thank you very much to the organizers for inviting me to speak today. And this is what my presentation is going to cover. I'm going to give a little bit of my personal and professional background, look at some of the issues that affect us and why we need to focus on health equity, and just finish off with leaving no one behind. So a little bit about me. I am originally from Kenya, but I am now a very proud citizen of Hackney, having lived in Dalston area for the past 21 years. I've also been living with HIV long time. I was diagnosed 28 years ago, and I've therefore had experience of accessing healthcare in the East London area. I have accessed the Homerton Hospital, the Graham Hayton Unit. Very recently, I've been a long-term patient at the Royal London Hospital, as well as being a long-term patient at the Maltby Hospital. And of course, I also like to say a huge thank you to my GP practice, the Somerford Grove Health Practice, which has looked after me for the past 21 years. I also have a personal experience of being a clinical trial participant. I was a participant in the PIVOT trial, which was a study which was comparing protease inhibitor monotherapy versus ongoing triple combination therapy for people who are already stable on the ARVs. I started off in the monotherapy arm and ended up going back to taking triple combination therapy because I had a couple of viral blips. I am also an advocate for the meaningful involvement and engagement of women living with HIV in research. So talking about proper, equal, and reciprocal partnership. I think one of the things that researchers and a lot of us tend to forget is the fact that clinical trial participants are also mothers, they're also researchers, they're also doctors. So basically they are beyond being clinical trial participants, they can also be involved in the life cycle of the clinical trial itself. And so by this, I mean, at the start, women can be involved in identifying and asking the right questions, in ensuring that research is relevant to researchers in the community. During the study setup, women can be, support the study trial by selecting the study acronym, participating in discussions around design and content, piloting questionnaires, reviewing patient information sheets, and reviewing all the study material. And during the study, women can be involved in identifying potential barriers to recruitment and ensuring that recruitment procedures are sensitive to participant needs. And then women can also participate as key members of the project management team to help monitor progress, identify problems, and find solutions. And at the end of the study, women can also support the study by supporting dissemination of results, co-producing community frequently asked questions and documents, and also be named as co-authors as well as co-presenting papers at relevant meetings and conferences. Next slide, please. In terms of my professional background, I am one of the founder members of the Forum Network of Mentor Mothers. This is a migrant-led perinatal peer mentoring project working with women living with HIV to train them to support their peers around the pregnancy journey and also for their own personal development. Although it is led by migrant women, we also work very, very collaboratively with all our mentor mothers living with HIV. Our focus is on the quality of life for women living with HIV to reduce stigma and support ongoing care. Our approach is evidence-based, it's forward-thinking, it's solution-focused, it's person-centered, and it is trauma-informed in order to provide personal peer support that builds confidence, improves mental health, and promotes positive affirmation. I'm also a member of the steering group member of SWIFT, and SWIFT stands for Supporting Women with HIV Information Network. It's a UK and Ireland knowledge-based network bringing together healthcare providers, researchers, activists, and advocates interested in research on HIV and women. I'm also a member of the study group for the Nourish UK study, which is going to be investigating infant feeding decisions amongst new mothers, pregnant and birthing parents living with HIV. Next slide, please. So I focus on health equity, and Chloe has already mentioned this because it's vital and clearly it makes sense. I just want to touch on some of the issues that affect us that then means that a lot of us then do not access healthcare equitably. So one of the reasons is late diagnosis. One of the issues is late diagnosis. And we know that when we're diagnosed late, it means quicker progression to ill health. It also means less time to engage in services, less time and lack of motivation to both take treatment and also to acquire treatment literacy, which would enable understanding of adherence. And we know that good adherence leads to a better quality of life. People are then able to work, to start families if that's what they wish, be in relationships, etc., and also give care effectively. I love this image because it's a photo, it depicts what, a typical African woman living with HIV. Yes, they have to take care of their treatment and their health, but then they also have family to take care of and they have to work. And so if they're able to take their medication properly, it just means that they're able to do the other things that they need to do in their lives well. And so therefore, it's really important to recognize the fact that, not being able to adhere to our treatment means we're not able to do what we're supposed to be doing to do it to them well. And Chloe also really already mentioned that, racial women and racial communities are underrepresented in research. And clearly that means if we're not involved, it means that we're also not involved in setting the research agenda, which we need to be doing, so that that research can actually benefit us. And so therefore, it really is important to recognize and acknowledge the fact that involving communities that are directly affected, which is what SHARE is doing, is absolutely key. And it is also incredibly important to acknowledge the community input by actually remunerating us fairly. Next slide, please. So for me, from a community perspective, it's wonderful to know that SHARE is planning to leave no one behind by meaningfully involving us in the planned research to ensure that the right questions are asked, that the research is about and with us, and that it will in turn benefit all of us. And it's great to know that SHARE is also going to link the strands that are needed to address the factors that contribute to our health inequality. And of course, as a citizen of East London, it's great that you're going to endeavor to ensure that we have equitable access to services and achieve better long-term health outcomes. I wanted to leave you with this photo of these friends of mine and colleagues. They're all women living with HIV. And the reason they're smiling like this is because they've been, over the years, they've been effectively involved in research. Thank you.
Thank you, Angelina, for that absolutely wonderful and vital introduction. We're so honoured to have had you here. It's a great pleasure to hand over to Professor Jane Anderson and Ms. Sadna Ullah, who will take over for the next part of this talk.
Thank you very much, Chloe. And my task, along with Sadna, is to talk a bit about the how and the who and how this SHARE Centre is going to deliver. You've heard from Chloe and Angelina about the need for the work and a little bit from Sheila about the collaborative. So Sadna and I plan to think a little bit about the philosophy, the ways of working, how SHARE fits into today's world and where its work is likely to have its most impact. A little bit about my background. I've worked as a clinician and as a researcher in the field of HIV in East and North East London since 1990, which feels very alarming, but I'm afraid is true. Initially as a senior lecturer at the Medical College of St Bartholomew's Hospital, transitioning into the newly merged School of Medicine and Dentistry within QMUL. And of course, I've always been embedded within the NHS services, both at Barts and at Homerton. And I learned early on the truth of Jonathan Mann's words, which he actually said in 1987 and are still as true now as they were then, that the epidemic of HIV, which leads to the epidemic of AIDS, is accompanied by the third epidemic of social, political and economic reaction. And it is that which is as dangerous and damaging to people as the virus itself. And so working with Professor Leslie Doyle from the University of Bristol, we carried out the first qualitative studies exploring the experiences of Black African heritage people living with HIV in East London. And we followed that up with some quantitative surveys across East London in partnership with Professor Jonathan Elford and City University. And actually, it's the experiences of undertaking those collaborative studies and the data that emerged that influenced the direction of my work from then onwards. And also, crucially, by the people who use the NHS services that we provide. And I have been witnessing over so many years the problems, the unmet needs, particularly of women, families, and people from minority communities as they are living with or affected by HIV and sexual health issues. And it's taught me very clearly that health is political with a small p. And seeing firsthand the power of collaborative working with social, behavioural, political scientists to deliver the evidence base for change is one of the most important things that I think we can take forward. And of course, I'm doubly privileged because I've had the great good fortune to work with the members of the SHARE team over many years. And Dr. Vanessa Appiah, Dr. Ageshri Darawan, and Dr. John Thornhill have also been trainees of mine over the past few years. And to see their work flourish and develop makes it even more exciting to be involved with SHARE and this initiative. So I'm absolutely delighted to be part of this whole project and today. Next slide, please. So I think Sheila has explained what SHARE stands for, the Sexual Health and HIV All East London SHARE Collaborative. And having an acronym is very important. It's important, as we all know, in clinical trials. All clinical trials now have an acronym. And so this is why we've chosen SHARE. And SHARE not only is an acronym for the words that matter to us here, but they are embodying what we believe to be the ethos and philosophy of what we're doing. We are going to be sharing our own experiences of health inequalities and the impact that they have on the people around us and on ourselves. We're going to be sharing the expertise, the resources, the data, and the intelligence needed to understand the fundamental causes of the inequalities that we see before us every day. We're going to be sharing the outputs of this work to influence and to make a difference. And we're going to share the learning of collaboration, partnership working, and co-production. Because for the health inequalities that we're also aware of to be reversed, they've got to be properly understood by multiple audiences. And in particular, they've got to be understood by the people that have the power and the leverage to implement the change that we need to see. And we believe that the knowledge and the intelligence that will come from the SHARE Centre will enable the development of effective approaches that are so urgently needed by health systems. So this is a multidisciplinary, multi-stakeholder initiative. You've heard it's between Barts Health Trust, Barts and the London School of Medicine and Dentistry, the wider University of Queen Mary, and crucially important, a partnership with the diverse populations of East and North East London. And of course, we're absolutely thrilled that Barts Charity have aligned their ambition with ours and have provided us with funding. And as I've said before in my previous work, the importance of working across subject and methodological boundaries if we are to get the data and the intelligence that we need to make a difference. And I was taught by a group of women living with HIV about the concept of evidence-based outrage. Having an evidence base alone is really important, but not enough. Being outraged at health inequity alone is important, but it's not enough. You have to have the evidence and the data to ensure that the outrage that goes with health inequity can actually be addressed. Next slide, please. So although we are embedded in East London in these particular 4 partners, we think, without being too grandiose and over the top, we believe we have got a much greater reach than that. And on the next slide, I've set out some examples of where I think our scope and our fit go together. So if we think locally, the aims of the SHARE Collaborative align with Barts Health and the SMD institutional strategies, driving innovations to improve health outcomes, to achieve outstanding standards of research, integrating multidisciplinary and translational approaches, educating PhD students, and achieving maximum impact in the wider community. And we believe that our approach on finding locally relevant solutions reflects the strategy of the university and the trust. And our unique community board structure aligns with respect to comprehensive plans for community and patient inclusion. And we're absolutely delighted with the new appointment of Dr. Fiona Waters, Professor Fiona Waters, who is going to be leading a new public health and policy institute within the School of Medicine and Dentistry, alongside the work of the Blizzard Institute. And of course, locally, Barts Health, we have the whole of the North East London providers of various sorts of sexual health and HIV. Integrated care systems are coming. We have an amazing opportunity there. We have the most amazing primary care networks, many of whom have already been involved with the work that we're talking about here. Our local authority partners who have responsibility for public health, and an incredibly vibrant public voluntary sector who we can engage and work with. And of course, in London, we have the London Vision, Sir David Sloman, which is of course undergoing change post-COVID, and Sadiq Khan's health inequality strategy. Of course, things may change tomorrow with elections, but nonetheless, that strategy has led us forward in tackling HIV. We have the London Health Equity Board, the Fast Track Cities initiative that Chloe has mentioned, and bodies thinking about higher professional education, the School of Nursing at City, a whole variety. And nationally, the Fenton Report, the Marmot Review, we're about to have a Department of Health HIV action plan, a new sexual health strategy, and we have huge and robust support from industry. And if we think internationally, only last week, the UNAIDS strategic plan was signed off with the top recommendation being that if we are to end HIV as a global issue, we have to tackle health inequity as stage number one. So we're completely aligned, I think, both locally and internationally, and the WHO strategy, which is about to be launched. So next slide, please. It's now my great pleasure to hand over to Sadna Ullah, because she is our new program manager who will help explain how this is going to work on the ground. So Sadna, over.
Thank you, Jane. Good morning, everybody, and thank you for joining us today. My name is Sadna Ullah, and I am the program manager for the Share Collaborative. I'll be very brief, but just to say hello to you all and introduce myself. For those of you that don't know me, I have worked alongside Chloe and the research team at Barts Health for many years, and this is a very exciting chapter of my career. I very much look forward to bringing the ethos of Share to life, where people from marginalised communities have a voice and real representation. Coming from a South Asian background and being born and raised in East London, I have witnessed the effect of inequalities within these communities, which is exactly why we need groupings like Share. I would also like to take this moment to quickly thank Chloe for giving me this opportunity, and very much look forward to developing meaningful work with this group. So a bit more about Share and the who and the how. So Share will sit under the Queen Mary University of London Health Directorate and Barts and the London School of Medicine and Dentistry. We will have a program board, which we will report to quarterly with our internal and external stakeholders. We also have a community advisory board, which will feed into the research vision and study developments within Share. And for each of the themes you'll hear more about today, there will be a core set of staffing, which we will recruit to. Next slide, please. And lastly, here are my contact details. Should you wish to get in touch, we are looking to collaborate for further research, and we'll be delighted to hear from you. Thank you, and enjoy the rest of the sessions this morning. I will now hand back over to Professor Chloe Orkin. Thank you.
Thank you so much for that, Sadna. It's wonderful to hear your voice, as you've been so pivotal to us delivering the grant, and remain so as we go forward in terms of managing this program grant. So thank you for everything that you've done. I'm going to speak about therapeutic equity, which is the first strand of our grant. So if we think about HIV treatments in 2021, it's all about pills. And our unit has contributed to the development of 13 drugs over my 15 years of working in HIV research, and we've been global lead for several of those drugs in terms of development. So in other disciplines, what we know is that long-acting treatments have improved engagement and outcomes. We can see that in contraception, long-acting methods have improved the outputs and engagement. In psychiatry, long-acting antipsychotics have transformed outcomes. And in osteoporosis, the treatments have significantly improved adherence and engagement. So what are the technologies for drug delivery in terms of long-acting methodologies? Well, there's a vast array of options. There are microneedle drug patches, subdermal implants, vaginal rings, wearable infusion pumps, and possibly in the future, oral nanomedicine with drugs that slowly decompose over a long period of time. But right now, what we have in HIV is a long-acting injectable treatment for the first time. And this is the first ever long-acting treatment in HIV, and we were the lead global site for one of the key studies for the development of this drug. And what we see with this drug is that at 2 years, if you look at the graph and you look at the left, the virological success, you can see that the graphs are almost equal. And this shows that cabotegravir long-acting with rilpivirine works as well as the oral treatment, which is an amazing statement in terms of longevity of outcome. And interestingly, in the US, the most recent guidelines have recommended that they can use long-acting cabotegravir rilpivirine within their guidelines. And importantly, their considerations include, and they specifically state that these therapies can be advantageous in patients for a variety of reasons, including but not limited to reducing pill fatigue, disclosures of concerns and stigma associated with daily oral medications, and improving quality of life. So they acknowledge the vital importance of these drugs. If we look at the long-acting treatment HIV drug pipeline, what you can see at the bottom is the HIV life cycle, and what you can see at the top is the fact that we now have drugs in development to target every conceivable point in the HIV life cycle, and this is incredibly exciting. The other point to make is that they are all being developed as long-acting treatments, so this really is the future. Within this grant, we will conduct clinical trials using novel long-acting treatments. We will focus on the drugs that have been highlighted in red. Islatravir is a first-in-class nucleoside transcription translocation inhibitor. It's in development daily as an oral 2-drug regimen together with doravirine, and we've led on this drug development. There's also been a once-weekly tablet in combination with MK-8507, which is in development. And the drug also lasts 1 year as an implant. So this has very exciting potential. The second drug we're going to be looking at is lenacapavir. This is a first-in-class capsid inhibitor, which is active both early and late in the life cycle, so has multi-stage activity. It's delivered as a subcutaneous injection, and the drug supports 6 monthly dosing with maintained drug target concentrations for 6 months, and a very good virological response in people with the hardest to treat virus. So this is a very important point. And there's very good news. There have been company announcements that Gilead and Merck will work together to develop and commercialize these 2 long-acting treatments of lenacapavir and islatravir in HIV. This is notable and of vital importance because in HIV, you need 2 drugs or more to create a viable regimen. So without this sort of collaboration, it's impossible to develop future therapeutics in terms of long-acting treatments. In terms of cure, you've all heard of things like the London patient, the Berlin patient, people that have actually been cured of HIV through very intensive and sustained and battering chemotherapeutic bone marrow transplantation efforts. And this isn't sustainable or possible for the general population for obvious reasons. But there is research going on that has shown in animals, in monkeys, a complete remission for the duration of 4 years. And this is akin to developing a vaccinal effect. These agents, which are also being developed to target COVID, and you may have heard of, in HIV, can be given 6 monthly. So therefore, they also have the potential to contribute to long-acting treatment. And they could also partner with other long-acting therapies. So one of our studies that we're about to start in our unit, we're going to be contributing to work, which is led by Imperial, Oxford, and the Rockefeller Group, in delivering a trial to compare the control trial of antiretrovirals plus a long-acting HIV-specific broadly neutralizing antibody. And this will be compared with antiretrovirals plus placebo in people with primary HIV infection, which is very early infection. And the aim is what will happen is we'll give these drugs and then we'll stop treatment and see if we can induce a virological remission in the same way as it's been achieved in monkeys. So we now have a situation where currently we can keep people alive for a normal life expectancy, which is a superlative and incredible achievement of the scientific community. And we have the tantalizing prospect of cure of HIV. And we have all of these drugs which can move us towards cure, some of which we'll be investigating in this grant. But it's always important to keep sight of the fact that when we can keep people alive for a normal life expectancy, we must make sure that we don't do studies that endanger the health of people that could be living a normal life expectancy in our excitement to achieve a cure. What about equity in therapeutics? If we look at international commercial clinical trials, they exclude and underrepresent. The last 6 new drug trials that have led to the registration of new products have recruited a median age of participants of the age of 33. Only 15% were women. And this is important because women represent more than 50% of the global population with HIV. Trans people were not counted. And people of color represent 33% of the people recruited into trials, and people with low immunities, low CD4 counts, the sick people, which we really need to understand the outcomes, represented 9% of the cohorts. Totally excluded are pregnant women. And here you see our editorial in the Lancet HIV. So we see that breastfeeding women are also excluded, and children are hardly studied in these trials. Women and trans people may have different outcomes. Adverse events can be different or worse, as we've seen with several drugs, and comorbidities can differ in terms of bone health and mental health. Also, drug interactions with hormones for trans people, contraception and menopause are important in terms of drug levels. And in pregnancy, this condition, the state of pregnancy, I almost called it a condition, the state of pregnancy can reduce drug levels by 25 to 30%. And at the bottom is this absolutely shocking bullet point, which tells you that the median time delay to acquire the very first data about drug concentrations after the license of a drug is in pregnant women 6 years in HIV, and in breastfeeding women 8 years. So they have to wait for such an incredibly long and awful amount of time till we get the first data on how these drugs work in this group. Who is the ideal patient for novel compounds? As Jane said, medicine is political. Medicine has a long and very ignoble history of experimentation on Black people, especially when it comes to fertility. Women in prisons in the States and offenders have been offered sterilization as recently as 2017 instead of jail time. Black women and poor women have been pressured into long-acting contraception and have been less likely to have it removed due to reluctance of staff. We need to be culturally competent and to understand and acknowledge history. When discussing long-acting treatments, we need to explain the possible benefits for the individual and not the public health benefit. Ultimately, we need to respect the decision not to take up long-acting treatments, as much as make sure that we're able to offer them to everybody. Here's another editorial from the Lancet HIV focusing on the fact that long-acting or extended release treatments must be tested in infants, children, adolescents, pregnant and breastfeeding women. We must assess the knowledge gaps and research priorities and leave no one behind. Importantly, learning from COVID, 2 COVID-19 vaccine trials in pregnant women are currently being planned. One of these will be led by us at Barts Health. What this says to me in terms of what it means for people living with HIV is that inclusion is possible. It can be done, as we can see from these trials. We need to have the will to push it forward. So with that, I'm going to hand over to my excellent colleague, Dr. Rageshri Deriwan, to continue.
Thank you, Chloe. Good morning, everyone. I'm just going to share my slides. Good morning, everyone. I'm Rageshri. I'm a consultant and honorary senior lecturer at Barts Health and at Queen Mary. And what I'm going to do today is to talk about our second strand of work, which is putting services within reach. But before I do that, I'm just going to tell you a bit about me. So like Angelina, I'm a citizen of East London, very proud to have lived in Whitechapel for 14 years, and the community and the area is very important to me. I started in sexual health and HIV in 2008 as a registrar and then consultant, and have worked all over East London and I've been supervised by both Jane and Chloe as a registrar, and worked with Vanessa and John as well. So I think I've been very lucky to work in a time of effective antiretroviral treatment for HIV. But over the years, I started to notice that the many advances in HIV that we've seen have not been felt by all groups. And this was particularly evident to me on the wards. And a recent audit we did of inpatients admitted to Barts Health with HIV really shows this. We found that 62% were being admitted with clinical AIDS defining diagnoses. And these were mainly people who were newly diagnosed and diagnosed late, or people who weren't in care, or people with a detectable viral load, so who weren't on effective treatment. And it was clear that certain groups were being disproportionately affected by this. So this has really guided my work. Since then, my clinical experience has really guided my policy and advocacy, for example. So for example, I was very pleased to work with Chloe and Sadhna to implement opt-out HIV and hepatitis C testing at the Royal London A&E. And we're restarting this year and aiming to expand to the other A&Es and Barts Health. I've also worked with national HIV policy organisations, including the British HIV Association as a trustee, the British Association for Sexual Health and HIV as chair of their sexual violence group, and the National AIDS Trust as a member of their clinical advisory group for migrants and HIV. I've also been lucky to work with communities on a real kind of community and ground level. So working with organisations that work and prioritise minoritized populations. And these have included NAS, 4M and Sahar. And more recently, working with NHS England on their clinical advisory group for COVID-19 and racially minoritized communities. And my clinical experience has also really impacted on my research. And I've been working in several collaborations looking at minoritized communities and health inequalities. And some of this work includes, for example, looking at intimate partner violence experienced by women living with HIV, a national study looking at HIV clinical outcomes amongst heterosexuals, which found that those from racially minoritized groups had poorer outcomes. Work with UCL on the PRIME study, looking at menopause amongst women living with HIV, and a recent publication from that which showed significant inequalities in socioeconomic status and mental health experienced by Black African older women living with HIV. We've also done some work looking at British South Asians living with HIV in East London, and this is a very under-researched group. And I was co-author on the study that Chloe mentioned with Vanessa and our ITU collaborators, looking at admissions to Barts Health with COVID-19 by ethnicity. And my current work is a qualitative study exploring the acceptability of immediate antiretroviral therapy to people living with HIV. So really trying to get a diverse sample to understand people's views. And I've also been working as a trustee of SWIFT, which Angelina previously mentioned, which is a network aiming to improve the clinical outcomes and well-being of women living with HIV. So moving on to tell you about the work that we're going to do in Strand 2, putting services within reach. So we know that in order for people to stay well and not pass HIV on to others, people living with HIV need to stay engaged in care and on treatment. And this can be challenging over the life course. We know that factors associated with disengagement from care include being of a younger age, from a racially minoritized group, length of time since diagnosis, poor mental health, complex social circumstances, and HIV-associated stigma. And as Chloe's mentioned, some of our outcomes are not as good as the rest of London. So for example, at our Stratford clinic, only 82% of patients are on treatment, with only 92% undetectable compared to 95% in the rest of London. And we also know that East London was disproportionately impacted by COVID-19 during the first and second peaks. And we saw something very interesting happen in the first peak of COVID. So right at the beginning, we started to notice that patients who hadn't contacted clinic for more than a year were starting to phone us, and they wanted to have blood tests done and they wanted to start treatment. And we found this very interesting, and we asked around and found that other London clinics were noticing this as well. And we presented this data at the International AIDS Society conference led by my colleague Suba. And we found that during the first peak, 60 patients re-engaged in HIV care at Barts Health, of which 73% were from racially minoritized groups. And we thought this was very interesting because we wanted to find out more. What was it that made people disengage from care in the first place? And what was happening that was making them come back? And how could we keep them in care? So this has really led on to this proposal for Strand 2. So the aims of this study is to examine the barriers and enablers for best HIV treatment and care outcomes. We'll use the experiences of disruptive change associated with the COVID-19 pandemic as a learning environment. And from this, we'll make recommendations for services to better support their service users stay in care and on treatment. And we'll use mixed methodology, so with 3 work streams. And in work stream 1, we'll select 10 London HIV clinics with diverse populations, and we'll do interviews to ask the service providers at this clinic what their service models are for re-engaging people in care. Workstream 2 will be collecting data on patients from each of those clinics. So we'll be asking them to collect data on patients that re-engaged during COVID, and we'll be following up the patients over 24 months to see what happened to them. So did they stay in care? Did they start treatment? Did they stay on treatment? And we'll also be asking the clinics to collect data on those that disengaged because of COVID. And in work stream 3, we'll be looking at patient experience, so using questionnaires and interviews to really find out the experiences of people who re-engaged during COVID and people that disengaged. And as I said, we hope to have recommendations for service providers to have services that are more reachable for patients. And we hope that this will be applicable in other settings, for example, in other HIV services around the world, so the US, for example, and you can see their cascade of care showing there's much work to do there about retention in care and viral suppression. And our findings may be applicable to other chronic health conditions. So for example, with adherence, we know that in chronic conditions, only half people take their medication as prescribed, and adherence improvement is a priority of the WHO. So we hope that perhaps if we can find ways in which we can better support patients to take their treatment, that some of our findings may be applicable for those conditions as well. So thank you very much for listening, and I'm going to stop sharing and pass on to my colleague, John.
Good morning, everyone. Please bear with me while I just share my slides. And I'm just going to start this. So I'm going to discuss the third strand of the shared collaboration, and that's looking at kind of basic science questions. So it's really basic science research for all. So in collaboration with Professor Patrick Kennedy, we will lead this strand, and we'll try and develop our understanding of the basic science of HIV and hepatitis and how this leads to persistence and the development of comorbidities associated with those conditions. And has been very eloquently stated already today, much research, including basic science research, is often not representative of the HIV epidemic. And we aim to include individuals who are often underrepresented in studies of HIV and hepatitis basic science research and lab research. So in terms of my background, well, I trained in East London, but at Homerton and at the Royal London. And I went off to do a PhD at Imperial College until 2018 when I finished. And I developed an interest in looking at gut immunology and HIV viral persistence. And much of this work was done under the umbrella of the Cherub collaboration, which is a collaboration for HIV eradication in the UK. And this collaboration allowed me to be involved in the recent London patient case, where I did an analysis on the gut reservoir in that individual 30 months after his treatment interruption. And this patient is now essentially cured of HIV after a stem cell transplant. My work is also focused on looking at markers of HIV reservoir in the gut and trying to understand the resolution of immune abnormalities in the gut after people start antiretroviral therapy. And it's very well documented at this stage that in primary HIV infection, that there is a dramatic loss of CD4 T cells in the gut. So this image on the right shows the absence of lymphoid follicles in the gut of somebody just who's recently acquired HIV. So you get a rapid loss of CD4 cells in the gut, and in many individuals, these never recover fully, leading to gut abnormalities. And we know that HIV can damage the integrity of the gut epithelium. So here on the left, you have healthy gut, and the idea is that when you lose all of these protective immune cells, you get breaks in the epithelial barrier of the gut, allowing bacteria and pathogens to cross into the bloodstream, setting up immune activation. And this can lead to poor health outcomes for individuals living with HIV. And again, much of this research has been carried out in gay white men to date. This is taken from some work by Denis Douek, where he nicely summarizes the impact of HIV on the gut and how this can lead to immune activation and subsequently inflammation, tissue damage, which can support non-AIDS morbidity and mortality. In addition, the damage to the gut causes activation of CD4 T cells, and these are actually targets for ongoing infection for HIV. So this also supports HIV persistence. You also get disruptions to the CD4 cells and the CD8 cells, which limits the ability of the gut in its pathogen control. So all of this can result in a vicious cycle that can result in poor health outcomes for people living with HIV. So HIV-2 is a related but different infection to HIV-1, and it's actually relatively, we encounter it relatively infrequently. It can be regarded as a neglected tropical disease. And it has its origins from the sooty mangabe as opposed to HIV-1, which is its origins from the chimpanzee. And HIV-2, although certainly pathogenic, has been shown to have a slower disease progression and a higher incidence of elite controllers and long-term non-progressors. And it has been suggested that it is an interesting scientific model to study a functional HIV cure. There has been some work by a Portuguese group that suggests that the gut may be key to this. So there seems to be preservation of gut immune cells in HIV-2 that isn't seen in HIV-1. So this is some data from that group where they basically show that the CD4 cells and the CD8 cells in the gut of people living with HIV-2 is similar to those who are HIV negative. And in East London, we have one of the largest cohorts of people living with HIV-2. And Dr. Jane Dayton runs a clinic for people living with HIV-2 at Barts Health. So we, in collaboration with Dr. Dayton, we hope to recruit to a cohort study of people living with HIV-1 and HIV-2, which will involve a gut biopsy. And this will allow us to investigate the virological and immunologic factors associated with disease progression and potentially identify targets in HIV-1 that are identified through studying HIV-2. We have also received funding from the Global Challenges Research Fund to carry out some work in collaboration with Professor Paul Kelly, who's based at QMUL and also at the Department of Tropical Gastroenterology at the University of Zambia. So this work is imminent, and we will be looking at gut immune dysfunction in a cohort of individuals who pre-antiretroviral therapy in Zambia. Finally, another aspect of this strand is to investigate the impact of hepatitis B and HIV co-infection. And Professor Patrick Kennedy is a world-renowned expert in hepatitis B. His work has looked at markers of hepatitis D disease progression, and he has published widely on this. So in collaboration with him, we will apply novel markers that he has developed to our HIV hepatitis B co-infected individuals to try and improve outcomes for people who are living with both of these infections. So these are my details if anybody wants to contact me, and I'm now going to pass on to Dr. Vanessa Appiah.
Thank you, John. And I'm just going to attempt to share my screen. Great. So good morning, everyone. I'm Vanessa Appiah, and a little bit about myself. Bear with me. Great. Perfect. So a little bit about myself. So I'm another East Londoner, born and raised in East London, actually born in Royal London. And I'm also a daughter of first-generation Ghanaian immigrants. And within that, I've really witnessed firsthand the impact of differential opportunities within East London. And throughout my career, my clinical work and my research interests really have been rooted in the belief that all people deserve a fair and just opportunity for health and well-being, and there always needs to be a relentless focus on equity. And I've been fortunate enough to work in sexual health and HIV over the past 15 years. And within sexual health, really championed a culture of developing a responsive service that's responsive to the needs of the local populations across diverse groups of people. Within the HIV service, also leading a clinic, which is the Link Clinic, which is a novel one-stop model clinic, which is designed to support patients to engage with care, bringing together people with from many marginalized groups experiencing stigma and having other complex and prioritized needs that does affect their ability to engage with care. Working alongside specialist nurses, social workers, psychologists, health advisors, and peer mentors to provide this holistic and tailored approach. But in terms of research, I was a co-investigator for REACH, which is a mixed method study to investigate the barriers and facilitators of HIV engagement to inform interventions. Also the co-investigator of HIV prevention studies within the UK and within Ghana as well. And particularly within Ghana, exploring the use of social networks and peer leaders to support people to engage with pre-exposure prophylaxis. But during the pandemic, I co-led and published research which with ITU colleagues to really highlight COVID-19 outcomes across different ethnic groups within our trust, recognizing, and it did highlight, that those of Black and Asian ethnicity had higher rates of hospitalization and mortality as compared to those of white ethnicity. But we know that these inequalities are not new, and alongside my clinical work and research has been my advocacy work to really raise awareness about these disparities and come together to see how we can approach them. Apologies, everyone, my screen keeps changing. So more than more have we seen the power of community that is so important within COVID, both in terms of directly supporting communities and in terms of supporting vaccine uptake and rollout. A community-centered approach with community members actively engaged and included in decision-making and implementation of community-level interventions. Over this past year, as NIHR North Thames co-lead for minority inclusion in COVID-19 research, I've been advocating for increased diversity of participation within trials. And also with this, doing work with vaccine uptake has shown that meaningful community engagement has been pivotal in changing the narrative and enabling change. And in response to the inequalities of COVID-19 outcomes, I'm co-leading a Barch charity-funded project, which is a community-based participatory study exploring the lived realities of ethnic minority communities in East London to further understand the drivers, but also co-develop community-based solutions. And this is the ideal study. So within Strand 4 and within that same vein, key to achieving health equity in HIV and sexual health outcomes is identifying and understanding the root causes and drivers of inequalities. So that way, treatment and prevention interventions can be appropriately tailored to mitigate these differences and optimize health outcomes. We're going to be delivering this research led by myself, Professor Anderson, and Professor Griffiths. Populations in East London, as we know, experience multiple forms of social disadvantage, and these intersect and overlap in ways that worsen their health outcomes, such as gender, race, socioeconomic status, and class. A lot of research only focuses on a single axis of this. We'll be taking a different and collaborative approach from the beginning, bringing together researchers from different disciplines to explore these domains together and be delivering mixed method research, ensuring that our work consistently is embedded and driven by local communities. The Amplifying Alive study, which is amplifying the lived experiences of East London communities, will undertake mixed method community-based research that will inform the design of tailored interventions that can be implemented and their impact assessed. Again, emphasizing that our research design is rooted in community participation. And we really intend to build on our existing and long-standing relationships with local community leaders. So our first study will look at this, will be taking the form of adapting a process which is the James Land Alliance priority setting partnership process. Now, this is an established framework of patient engagement, which enables clinicians, patients, carers, and other people to work together. And it comprises quantitative surveys, qualitative interviews, and workshop interactions that have been used across different specialties and ethnicities globally. And typically, these are used to co-prioritize health research topics and shape research agenda. And here we're going to co-prioritize and co-develop interventions. So we're going to establish an East London priority setting partnership, and this will be comprised of key health care providers, community groups, patient representatives, and academics. And this will enable us to authentically engage and consult with local communities to develop a deep understanding and to define lived experiences that are so important to drive our work. Our first study will be the lived experiences of women of Black African heritage in East London, which is a marginalised group and seldom heard. We really acknowledge the diverse groups within East London, but we have taken this opportunity to focus on this group first. We will undertake focus group discussions amongst the steering group to inform the design of quantitative and qualitative interviews. We will then work with our priority setting partnership to ensure genuine representation and inclusion across the population that will participate in the survey, and then be followed by these in-depth interviews in a subset of these respondents. And based on these responses, we will learn the key enabling and limiting factors which drive health outcomes. We are then going to come together in prioritization workshops and develop a top 10 of their health concerns and recommendations for interventions. We will then work with a subsample to co-design a tailored intervention. And also within our work, documenting health narratives will be key. And one narrative that we are going to be exploring is the experience of late diagnosis in our target groups. First of all, we will be identifying and recruiting women of Black African heritage who were diagnosed late with HIV. We'll be performing narrative, in-depth interviews, asking them to recount their journey from diagnosis, highlighting barriers related to access, socioeconomic status, gender, and COVID-19. And then performing a grounded analysis to create a rich picture of experience and areas to target through new bespoke interventions. As part of our overall efforts to be a collaborative group, we want to ensure the authentic and representation of our community. We will be establishing a remunerated local community advisory board to provide input, define and challenge the design, development, implementation, analysis, and dissemination of our research. Thank you. And now I'm going to hand over to Sheila.
Thank you very much indeed. I'd like to thank all of our speakers for providing a very compelling set of presentations that I think have covered everything from the importance of the vision that SHARE embodies to the very practical changes and differences that the work that colleagues do across the piece can make at the front line. And I think what's been really compelling is that we have everything from local impact to global impact covered. And also I was very struck by the fact that there is such a commitment to involving marginalised groups who have had no voice in this research, both in terms of how research is defined, the participants involved in it, the researchers conducting the activities. And I think there have been so many vital themes that have been identified this morning, which for me really makes such a compelling case for the importance of promoting health equity. So can I just thank everybody very, very much indeed for for all those presentations. I'd now like to open the floor to questions, if I may. I'm conscious that there are a couple of questions already in the chat. What I might do, if colleagues are happy, is to start with those and to invite any others that you'd like to post in the chat. So perhaps if I could start with a question from Luis Guerra. I'm just going to read it out in its entirety so that I don't lose the essence of it. The latest National HIV Self-Sampling Service report, PHE, shows Latinx people have the highest reactive rates in England. However, this community remains invisible across research, reports and data collection systems. How can this initiative help address the needs of invisible communities where no data is reported or collected systematically? For example, Latino Americans. The Latinx community in East London is vast. Could I perhaps invite somebody to answer that question? Thank you.
I'm happy to go first.
Thank you, Vanessa.
No, thank you, Sheila, and thank you, Louise, for your question. Completely agree. And I think when we've been looking at the minority communities to include, well, I feel really strongly that a lot of research that is done tends to lump people together. And what we want to do is to be really distinct and to give the right time and appropriate focus on individual groups that form the term of ethnic minority communities. So we have chosen women of Black African heritage before, partly for my personal interest, definitely, and be very honest about that, but also because it is a group that is seldom heard. But we also acknowledge the different groups that are within East London, and we will be focusing on those communities as well. So definitely aware, definitely acknowledge, and what I will say is their time will come in terms of us focusing on them.
Vanessa, thank you very much indeed. Can I just ask if anyone else wants to come in on that particular question, or shall I? Jane?
I just add something to that, because I think one of the points that Lewis has flagged up is the way people are counted. And so actually some mechanisms for counting don't really include Latino communities in the boxes that we're looking at. And I think this is a real failure. So I think Hackney, for example, includes people from South American backgrounds within an ethnic minority classification, but other boroughs don't. So there needs to be some uniformity of counting and measuring, because actually I think that we underestimate the impact. Better measuring, and then I think, as Vanessa said, focusing on the particular issues in that particular way.
Thank you very much indeed, Jane. So we now have a question from Sophia Forum. If you have well-controlled HIV, poor absorption of nutrients in the gut? I said John might answer this.
I'm happy to take that one, Julie. Yeah, thank you. So it's a really interesting question. So I think that the answer is no. I think there's no problems with malabsorption for the vast majority of people living with HIV, particularly people who are well controlled and on treatment. What we do find is in a subset of individuals, they probably have some damage to the gut that leads to this immune activation. So in a study that I was previously involved with, we looked at treating people very early, and the vast majority of immune markers in the gut were normal after treatment, but there was a subset of individuals where that wasn't the case. So you see evidence of that bacterial translocation where you get inflammation resulting from damage to the gut. But for the vast majority of people on well controlled on treatment, this isn't a problem.
John, thank you very much indeed. I'd now like to go to a question from Dana Rosenfeld. Excellent and exciting presentations, thank you. I was wondering about the age dimension. I work on aging with HIV, and unless I missed something, I didn't hear anything about older people living with HIV. Who'd like to come in on that?
I'm happy to take that. Dana, thank you for raising that, and it's such an important point. And I think that in one of my slides, what I showed is that in terms of recruitment to clinical trials, the median age is 33. And I think this is one of the health disparities and inequities that is really very clear to see. And in terms of our focus is inequities wherever they exist. And this is our, as Vanessa said, these are our first steps. but we would be very keen and open to collaborations to address all inequities in terms of what Louise has said and what Dana has said. And I think that viewing things from an intersectional lens, the ways that gender, age, ethnicity, religion, everything intersects is really the vital way of integrating health inequities and the understanding of disparities. And I think that the type of research that we plan to do is inclusive. And that means including everybody and representing people on our community participatory boards. And in terms of the type of basic science research that we do. And we very much plan to be representative, but we're very much open for business, for proposals of work in any specific populations. I don't know if anyone else would like to come in on that.
Chris.
Well, certainly, yeah, it's an important question. I mean, certainly the questions about late diagnosis. If older people are diagnosed late, we'd be very much wanting to explore the reasons why they were diagnosed late. So, that would be encompassed within the studies that we're planning in Strand 4. So that's a very interesting area to pursue. So thanks for raising it.
Thank you very much. John?
I was going to say, as people get older, they tend to have more problems with immune activation, often irrelevant to HIV, so related to other viruses like CMV. So it's definitely something I'd be interested in looking at as well in my research, but no immediate plans, but definitely something I'd be open to doing.
Thank you very much, John. Right, moving on to the next question. We have a question from Shanwit Kifetu. Sorry, my screen suddenly jumped up. Will there be any prevention-focused research?
I'm happy to take that. So the long-acting injectables, particularly cabotegravir or pivarine at the beginning, the one that I mentioned, these drugs have had the most stunning results in terms of preventing HIV in PrEP. And both across men, transgender people, and cisgendered women. And in fact, they've managed to show superiority, so they're actually better than all treatments. And our work in long-acting treatments and our expertise in these drugs will position us and align us to do this work. We have a very strong track record in HIV testing, which is, as Rageshri mentioned, across our group and also in terms of the work that Chris and Jane have done for many years. And this will enable us to identify ways and groups that may benefit from these types of agents.
Chloe, thank you. Right, I have a question from Sara Paparini. Firstly, really exciting plan for a fantastic group. I have a question re community engagement. How do you envisage these connections? Would this be through our brilliant existing community organisations or approaching existing patients, etc.? It may be an idea to set up an ongoing paid advisory board for participatory research across studies. This may be a benefit for the centre going forward and increase and strengthen the research capacity across communities. Can I invite someone to answer that?
I'm happy to start. So in terms of community engagement, I think it is definitely building on our connection so far, but at the moment, as I said, we're doing the IDEAL study, which is bringing together different community members across East London and creating our first priority assessing partnership. And it's actually been fantastic. I think the vaccine engagement work has been really powerful in identifying kind of the bigger known organizations and some of the smaller grassroots organizations as well. And those organizations have been fantastic conduits to a number of communities that we just typically haven't engaged with before. So it is really building on our connections, but and it's building not just within the HIV sector, but outside of the HIV sector as well, and also leveraging the experience that we've gained through the vaccine rollout. So definitely that. The other element, yes, we are going to have a paid advisory board and really believe in the importance of remuneration, acknowledging people's time, expertise, resource, and actually their lived experience is what we're capitalizing on. So it is really important that we remunerate them. And we are really hoping that that acknowledgement will be a key factor in keeping that ongoing engagement and retention in our work across the research journey.
Vanessa, thank you. Did anyone else want to come in? Well, that's a very comprehensive response.
Can I just add one thing? I think Vanessa said most of it already, but just to say in some of our strands, we'll also be employing peer researchers to do some of that qualitative work, because we recognise that, you know, they're often the best way of recruiting participants and getting, you know, the answers and the questions that we need.
Great, thanks, Rajeshri.
And I would just say absolutely. And I think it's important to recognize people's expertise. And as you heard from Angelina, she has experience both in contributing to research and participating in research. And it's important not to take paternalistic approaches that draw from people's voices, but don't actually include them in the ideas stage and the academic aspects, because that denies people's ability to inform the process.
Sorry, may I just add something actually, just something that's just come to my mind as well, is that also what we've learned with the engagement that we're doing at the moment is that there are some people that are kind of professional engagers and feel comfortable to have a seat at the table and to articulate their concerns. But we also recognize the importance that some people may not have that confidence or experience. And so training is budgeted within our work as well to support those from the community to have more of a voice within our work.
Vanessa, thank you very much indeed. A couple of more questions and comments. Ditu Chowdhuria, thank you all for assembling a model of health and social care investigation that benefits the 21st century. Is there any medical group that you can take guidance from, or are you out there on your own?
Yeah, that's an interesting point. And thank you for your commendation of our attempts to befit the 21st century and to encompass the entire cascade of care. I don't want to aggrandize ourselves, but I am not personally familiar with a group that spans the entire continuum. I think there are people that do outstanding work in the different elements of HIV continuum of care, but to try and span the entire continuum and focus on inclusion across basic science through development of new drugs to community participatory research at every stage. I think that this is potentially novel, certainly novel in the UK. I don't know if any of my collaborators would like to come in on this.
I think we're unique.
Succinct and helpful, Chris, as ever.
Very succinct indeed. Panelists, can I ask, I've got a couple of more questions in the chat. Would you have time for me to just put those to you very quickly?
Yeah, you may as well, and we can stay on the line.
If that's okay.
Want to stay on the line, yeah.
And I have, so I have Patricia McGettigan. What is the plan for examining comorbidities other than hepatitis-related diabetes, CVD, and so on, and associated with the multiple medication use?
I think I'll start on that one. Thanks, Patricia. So it's definitely something we would like to look at. So there is a wealth of resource at Queen Mary. So there's the Barts bioresource. So there is there's infrastructure in place to collect samples for, you know, a larger cohort of individuals, where we could carry out work looking at things like cardiovascular disease, cancer, and answer other questions. But in the immediate term, none of these things are planned, but they're definitely something we'd be open to doing in the future.
Yeah, thanks, John. That's a great answer. And I think, as John says, we've reached out to the Biobank, and we've asked to be the first sort of non-cardiac specialty to donate to the Biobank. So they did this in COVID, but we've approached them as a smaller and manageable specialty to try and start collecting a biobank, because this will be vital to John's work. And John's work really lends itself to work in comorbidities. But as we're starting out, we've got money for these specific projects, but are very keen to apply for blue chip grants to address other areas. And comorbidities is clearly key. And understanding, given the data that I presented from Rageshri's piece, we can see how our populations are subject to health inequalities that make them more likely to have many cardiovascular problems, more likely to have these problems, and therefore are so much worthy of study.
Great, thanks, Chloe. Final question from Simon Collins. Great to see this research programme getting a high profile. Researchers and advocates in East London are generating world-class studies. Is community engagement included in the budget to support advocates with appropriate training?
Thank you. Just reinforcing, thank you, Simon, and reinforcing what I said earlier, very much so. And that is really important to us. So we've acknowledged that. We'll be learning along the way as well to think about the types of training that's needed. We've got an idea, but I'm sure as we roll it out, more learning will come.
Vanessa, thank you very much indeed. So we've overrun by a minute, so apologies for that. But can I just extend my very grateful thanks to the audience for their wonderful engagement with this topic, and a huge thank you to our panelists for an absolutely inspiring morning. I think you've generated huge excitement and engagement with the work that you're doing, and I think you can look forward to quite a few people engaging for future involvement with the work that you're doing. So a huge thank you to you all. Thank you very much indeed, everybody.
And thank you to Bart's Charity once again for their support.
Absolutely. Huge thank you to Bart's Charity. Thank you, everybody.
Thank you, Sheila.
Thank you, Sheila, for hosting us and looking after us so well. Thank you.
It's a pleasure. Thank you. Bye.
Bye.
Bye.